Hey everyone, welcome back to FNP University, your premier source for medical education. We are back with the next part in our Differential Diagnosis series. Our goal is to help you navigate the complex world of medical education. If you are not a nurse practitioner, you are still in the right place, as many of our topics relate to so many roles in healthcare. Let's get started. Today, we're going to discuss a case that might surprise you like our last case. Let's meet our patient, Mrs. Johnson. She's a 29-year-old, pleasant, overweight African-American female who is a practicing pediatric psychologist. She has come to the emergency room complaining of 5 days of uncontrolled, fast breathing, insomnia, worsening fatigue, and increased thirst. She denies any recent changes to her weight, which she has struggled with since she can remember. She does mention quite a bit of stress in her new role and thinks this may be a culprit. She also reports getting over a recent COVID-19 infection about a week ago. In step 1, we gather information. We've taken a detailed history and conducted a physical examination. Mrs. Johnson's symptoms could point to several different conditions, from anxiety to thyroid disorders to diabetes. We don't know her family history, as it's not something talked about in her household. Her physical exam is grossly unremarkable, other than her fast breathing and a sweet smell on her breath. She did report chewing gum, as her mouth has been unusually dry. Step 2. We categorize her symptoms. Given her chronically elevated weight and symptoms, we're particularly concerned about her endocrine system. Step 3. We prioritize our possibilities. Given her symptoms and presentation, the most serious and pressing diagnosis might be type 2 diabetes and its effects. But we must also consider other possibilities like anxiety, especially given her profession, or thyroid disorders. In step 4, we decide on further investigations. We should consider laboratory studies such as fasting blood glucose tests and hemoglobin 1C to check for signs of diabetes. We should also assess her thyroid functioning to include TSH, T3, T4, and antibody testing to assess for any autoimmune disorders. In step 5, we reassess and update our differential diagnosis as new information becomes available. Mrs. Johnson's blood tests show nearly zero serum insulin, elevated blood glucose, and elevations in hemoglobin A1C levels, along with the presence of GAD antibodies, EA2A, and, importantly, zinc transporter 8, ZN-T8 antibodies. The presence of these autoantibodies, especially ZN-T8, which is an independent marker for autoimmune diabetes, can help confirm the diagnosis of latent autoimmune diabetes in adults, LADA, an unexpected outcome given her age, weight, presentation, and profession. This new information would move LADA to the top of our differential diagnosis due to confirmatory testing. Now, the fruity-smelling breath made sense, as she was in diabetic ketoacidosis. It was acetone we smelled and not gum that masked it. Remember, building a differential diagnosis is a dynamic process. It's not about jumping to conclusions, but systematically working through the possibilities and using the best available evidence to guide our decision-making. As we have seen in this case, which will be true in many cases, you will not have complete or accurate information when formulating your plan. This is why Step 5 is so crucial, as we have to change our differentials to adapt to new and more complete information. We would love to hear your experiences with building differential diagnoses. What strategies have you found helpful? Share your tips and tricks in the comments below. Did the patient's outcome surprise you, or were you spot on from the start? Building a differential diagnosis is a crucial skill for any healthcare provider. It helps us think critically, be systematic in our approach, and use evidence to guide our decision-making. We were able to save the patient's life even though she didn't fit either of the typical diabetic patient profiles. It's also worth noting that LADA typically affects patients over the age of 30, although it can occur at any age. Studies have also shown that viral infections, such as Mrs. Johnson's recent COVID-19 infection, can trigger latent autoimmune disorders. Because the symptoms can be subtle and gradual, LADA is often misdiagnosed as type 2 diabetes. This case is especially tricky due to the specialized testing needed to effectively diagnose LADA and the atypical presentation that can cause misdiagnosis. Fortunately, we used the 5-step method as well as our instincts to effectively diagnose Mrs. Johnson. After 4 days in the ICU, she was discharged on insulin therapy and returned to a mostly normal life, and most importantly, back to treating her patients. Her follow-up and routine care should include further autoimmune testing, as she is predisposed to other related conditions like rheumatoid arthritis and autoimmune thyroiditis. She is also in need of intensive education and consultation with a nutritionist to help her adapt to this life-changing diagnosis. For more in-depth discussions and guides, visit our website in the description below. Don't forget to like, share, and subscribe, as it helps us to bring you more videos like this one. As always, be well and stay healthy, and see you in the next video.